purposes.
This meeting is being recorded.
Okay, now it's 9 o'clock. I think we should start. Thank you all for attending. Today we'd like to thank Dr. Wim Ceelen from Belgium, who's going to be talking about colorectal peritoneal metastasis. Thank you, Dr. Wim, for joining us. Please start.
Okay, so thank you so much for this kind invitation. So I will focus on colorectal peritoneal metastases, and I will share with you some new insights into the pathophysiology and some novel treatment options that may be on the horizon. So peritoneal metastasis is not that rare, and as you may know, about half of the patients with ovarian cancer, for instance, will present with peritoneal metastasis. In colon cancer, it's about 1 in 4 to 1 in 5 of patients who will either present with peritoneal metastases or will develop peritoneal disease in the course of their disease history. And then, of course, other GI cancers like upper GI, pancreas, stomach, hepatobiliary can also cause peritoneal metastases. And in that case, they are really associated with a dismal outcome. What is interesting is that some cancers that are located entirely outside of the peritoneal cavity may metastasize to the peritoneum, and well-known examples are breast cancer and a specific form of breast cancer, the so-called lobular type. So it's a specific histological subtype, and lung cancer and melanoma can have the same behavior. And then, of course, the peritoneum itself can be the source of the malignant transformation. And we know that peritoneal mesothelioma has a lot of similarities with pleural mesothelioma, which is traditionally linked with exposure to asbestos. So with peritoneal mesothelioma, this link is less obvious. We often see it in very young patients who clearly never had any exposure to asbestos. And then there's the primary peritoneal cancer, which is in fact both histologically and in terms of treatment options identical to ovarian cancer. And we now know, by the way, that ovarian cancer is not originating in the ovaries in almost all patients, but it's originating in the peritoneum close to the ovaries. For instance, the peritoneum on the side wall of the pelvis, or the peritoneum that covers the tuba. So this is a schematic view of how the process of peritoneal metastasis can be conceptualized. So you see here a cancer in the right colon. The cancer cells are being shed from the surface of the cancer, and this is due, for instance, to the elevated interstitial fluid pressure that is present in cancer tissue because of the lack of a functioning lymphatic system and hyperproliferation of cancer cells. There is an increased pressure in this tissue, and this then leads to shedding of cells inside the peritoneal cavity. And once inside the peritoneal cavity, they will travel around and they will stick to the mesothelial surface, not at random, but at quite specific locations. So some locations are at risk, as you may know. For instance, the diaphragm, so the surface of the right diaphragm is at risk because at every respiratory movement, these cells are really drawn to the upper abdomen by the forces that are generated by the excursion of the diaphragm. And also the omentum, the major omentum is an organ at risk. I'll come back to that later. The pelvis, due to gravity, because cancer cells fall down due to gravity, and also the paracolic gutters on the right side and on the left side. And so once these cancer cells stick to the mesothelium, this is step 2 here on the cartoon, then there is a specific mechanism of adhesion, which is mediated by adhesion molecules, such as the integrins, VCAM, ICAM, etc., platelet adhesion molecule. And this is then the first step that will ultimately lead to destruction of the stroma, which is underlying the mesothelial cell layer, and this invasion of the submesothelial stroma is then really enhanced by production of enzymes such as MMPs, matrix metalloproteinases, and this will then ultimately lead to the formation of real cancer nodules against the peritoneum. So this is an illustration of this elevated solid stress and interstitial fluid pressure, which then leads to shedding of cells at the surface of the tumor. At the same time, there is a process called EMT, or epithelial to mesenchymal transition. This is a very specific behavior where epithelial cells, in fact, transmutate into a mesenchymal shape, and this mesenchymal shape will then allow the cancer cells to have invasive properties and also motile properties. So they will have the ability to migrate, for instance, through vessel walls, but also through the mesothelial lining. You can see that here on the right side of this cartoon. So the normal epithelium is the blue cells, then the cancer cells are in yellow. And once the cancer cells are undergoing EMT, so epithelial to mesenchymal transition, you see that they become spindle-shaped and they acquire the phenotype, but also the gene expression of mesenchymal cells, and they very much look like fibroblasts. And they are sometimes in this stage, by the way, called CAFs, or cancer-associated fibroblasts. And so this allows the cancer cells to travel around in the body to cause peritoneal metastases, but also cause liver lung metastases. And once in the target organ, the reverse process can happen. So mesenchymal to epithelial transition, so MET, or the reverse process, which then allows them to establish a metastasis at the target organ. Now, what is interesting is that recent studies, and we have done some work on that ourselves, and this will be published in the next few months, is that there's also a process called MMT, or mesothelial to mesenchymal transition. And in that case, the origin or the source of these cancer fibroblasts are not the cancer cells, but the mesothelial cells themselves. So that's quite interesting. It has been observed in ovarian cancer, and we have just observed this in colorectal cancer. So the mesothelial cells, the normal mesothelial cells, are transformed into cancer-associated fibroblasts. And this is something you can measure by using, or observe by using, very specific immune histochemistry. And in fact, this process has been known to exist in the world of peritoneal dialysis and nephrology. We know that patients who receive long-standing peritoneal dialysis to replace kidney function, they also are known to show this behavior of the mesothelial cells, which then form cancer-associated fibroblasts, and these fibroblasts will then deposit ECM proteins such as the collagens, fibronectin, etc., and this will lead to a fibrosis of the underlying stroma, and this then will, in patients undergoing kidney replacement therapy, so peritoneal dialysis, this will in the end make the therapy less effective because the barrier is really getting obstructed by fibrosis. So this is a cartoon coming from our own work in this field. So as I mentioned here in green, the normal mesothelial cells, which are then really acquiring a spindle shape morphology and are in fact transmutated into so-called CAFs, so cancer-associated fibroblasts. So this is in colorectal cancer. Now, these cells that are being shed by the primary tumor can either be shed as a single cell, but what is also quite common, specifically in ovarian cancer and in mucinous colon cancer, is that they will be shed as a group of cells, so-called collective dissemination and invasion. And this is quite interesting. You see here two examples from two different publications. On the left side, this cartoon is showing what happens in ovarian cancer. So these ovarian cancer metastatic spheres are shed into the peritoneal cavity, and these spheres contain then some leader cells and some trailing cells, and these leader cells here depicted in greenish, they will then interact with the mesothelial surface and be responsible for invasion of the mesothelial layers. And on the right side, this is a similar mechanism of collective dissemination, so where really clusters or groups of cells are liberated from the primary cancer, and these clusters then travel around in the peritoneal cavity. And this is an example from what is observed in mucinous colorectal cancer, where you have these clumps or clusters of cells where it's interesting that they have an inverted polarity. So the apical side of the clusters is really pointing outwards, and this then will enable collective invasion of the submesothelial stroma. So this was published a few years ago by a group in France. This is just an overview. It's not that important, but it's just an overview of all the specific molecular interactions that are responsible for the sticking of the cancer cells to the mesothelial cells. So you can see here these integrins and several related molecules that act as a kind of a Velcro, as a kind of a zipper, and then will, in the end, be responsible for submesothelial invasion of the stroma. Now, a recent mechanism that has been described as being responsible for peritoneal metastasis and sticking of cancer cells to the mesothelium are the so-called neutrophil extracellular traps, or NETs. And what this is in fact a kind of a spider web consisting of decondensed chromatin, so it's DNA material in fact, together with chromatin, and this is expressed by neutrophils that are stimulated in some way, usually by inflammation. So if there's inflammation in the peritoneal cavity, these neutrophils will express chromatin on the outside of the cell, so extracellularly, and these will then form the so-called nets, or neutrophil extracellular traps. And these can then mechanically capture cancer cells that are traveling around in the abdomen. There are a lot of other processes that have been associated with these nets, and so NETs, but they are now assumed to be important in mechanical trapping of cancer cells in the peritoneal cavity. And so that's one of the first steps, of course, of the peritoneal metastatic cascade. This is a study that has shown, in fact, the importance of these neutrophil extracellular traps in an animal model of peritoneal carcinomatosis. And what was shown here, if you look at the axis, which shows the extent of peritoneal disease, that it gets a lot lower when you treat the animals here on the right side with DNAs. And so this shows that if you break down these neutrophil extracellular traps by giving DNAs, which will break down the DNA, which is really the consisting element of these traps, then you will no longer have peritoneal nodules in this mouse model of peritoneal metastasis. And so this is an indirect proof of the importance of neutrophil extracellular traps in the pathophysiology of peritoneal metastasis. Now, since I assume that the audience this evening is mainly consisting of surgical oncologists or surgeons, you know, of course, that the omentum is at risk for peritoneal metastasis. And in fact, we don't really know why this is the case, because what we do know is that the omentum in rodents, but also in humans, consists of these or harbors these small clusters of immune cells. They are called the milky spots. And as you can see here on this cartoon, these milky spots are really consisting of B cells, T cells, macrophages, and we know that the omentum has an important role in control of infection. If there is an infectious process like appendicitis in the abdomen, it will get walled off by the omentum. So the omentum has an anti-infectious role and behavior. And so why the organ is at risk for peritoneal metastasis is really not at all clear. There are several hypotheses. One of the hypotheses was formulated a few years ago in Nature Medicine, and this states that the cancer cells that are sticking on the omentum will in fact use the omentum or the fat in the omentum as an energy source. And so this is one hypothesis that was formulated, but whether or not this is the only reason is really not clear. Another theory has again to do with these neutrophil extracellular traps, and it has been observed in preclinical models and in mice models that in the omentum you have again these activation of neutrophils which will express NET, so extracellular traps, and these will then facilitate the formation of peritoneal metastases on the omentum. You see this here stepwise. So there's a neutrophil influx into the omentum. You get activation of the neutrophils by interleukins, interleukin 8 here, for instance, but also other chemokines. Then the nets are expressed, like the spider webs here, and they will then mechanically trap the cancer cells, which are then growing onto the omentum. And again, if you give an inhibitor such as DNase, which will of course break down the DNA and will break down these spider webs, then the hypothesis at least is that you will have a decreased tumor load on the omentum. But again, this is all very recent data, and I think the real mechanism or the real hypothesis is not yet very clear. Now, once the cancer cells have gotten attached to the mesothelium and have interacted using these very specific adhesion molecules, there is an invasion and a destruction of the submesothelial layer. And what this layer is of course depending on the anatomical location. If it's a peritoneal metastasis against the diaphragm or against the ventral abdominal wall, it will be striated muscle. But it could, of course, also be fat tissue if it's a retroperitoneal peritoneal metastasis, or bowel wall, or liver surface, etc., etc. And we know that the specific tumor microenvironment will be different according to the anatomical location. We are now investigating this with single-cell RNA sequencing and other fancy techniques. And we take samples, peritoneal metastasis samples at different anatomical locations in the abdomen. And what we observe is that this microenvironment is really different according to the location. For instance, an omental metastasis has a very different microenvironment compared to a diaphragmatic peritoneal metastasis. And so invasion of this submesothelial layer is mediated by proteases, so mainly the matrix metalloproteinases, and it's specifically effective in regions where the mesothelial layer has already been damaged by previous surgery. We know that port site metastasis, for instance, in ovarian cancer is quite common, by intraperitoneal infection, or by a local aggression of the mesothelial lining. And we know that CO2 insufflation is in fact quite bad for the peritoneal defense, specifically if you use non-humidified, dry, cold CO2 gas. So you cool down and you desiccate, you dry the mesothelial cells and they will shrink. The same with chemotherapy. Intraperitoneal chemotherapy, of course, will be toxic. Specifically, oxaliplatin is toxic for the mesothelial cells. It can cause fibrosis, etc. High loads of glucose are damaging the mesothelial cells. We know that again from the literature in nephrology concerning peritoneal dialysis. We know that dextrose, high loads of dextrose, if you give it a long time repetitively, it will damage the mesothelial cells. Now, the colon cancer is not one disease. It's in fact 4 different subtypes. And this is depending on, of course, gene expression. And we know that the traditional subtypes, consensus molecular subtypes, are type 1 and 2. And what is interesting is that the peritoneal metastases are usually type 4. And type 4 is characterized by mesenchymal behavior and is driven by tumor growth, transforming growth factor beta, and is really characterized by the presence of a lot of fibroblast activation and the deposition of a lot of stromal proteins, so very fibrotic tissue often. And on the right side, what you can see, so the cartoon on the left side gives you the difference between these consensus molecular subtypes. It's not really that essential, but what you see on the right side from this clinical study published a few years ago is that when they looked at a comparison of these molecular subtypes between the primary cancer of the colon and the CPM, so the colorectal peritoneal metastases, then there was a clear difference between both. For instance, CMS4 was present in 31% of the peritoneal metastases, but 0, so none of the primary cancers were CMS4, but more than 30% of the peritoneal metastases were CMS4. So what this means is that you get a change in molecular subtype and a change in microenvironment as soon as you get a metastasis on the peritoneum. And so it's a question of the seed and soil hypothesis. And so you get a different behavior of the metastasis depending on the soil where it is growing. So that's probably the explanation. So how can colorectal peritoneal metastases be treated? Well, first of all, systemic treatment like chemotherapy, antibodies, and so anti-cancer antibodies like cetuximab, panitumumab, bevacizumab, they are all effective. It's sometimes stated that chemotherapy doesn't work for peritoneal metastases. That's not true. That's clearly not true. It does work, but it's a little bit less effective than in patients with liver metastases, for instance. So systemic therapy works, and then in some patients, it makes sense to combine it with some form of local therapy or local regional therapy. And so that can be surgery, of course. That can be intraperitoneal chemotherapy, like HIPEC, EPIC, PIPEC, etc. It can be hyperthermia alone, like external hyperthermia. This is available. There are external hyperthermia machines that work with microwaves, and it looks a little bit like a CT scan. So the patient goes in the machine, and then the abdomen is heated. It's often combined with radiotherapy. Photodynamic therapy is not often used, but it's coming. I have the impression that there are more and more studies on photodynamic therapy in patients with peritoneal metastases. And then electrical fields, the so-called TTFs or tumor treating fields, are also now in clinical trials. I remember there was in Belgium 2 years ago a clinical trial in patients with ovarian peritoneal metastases who were treated with these electrical fields. So the patients had some electrodes stuck on the abdomen, and then these electrical currents, of course, low voltage, low power intensity, and this then is assumed to have an effect on the behavior of the cancer cells. This is a table that is probably not so easy to read, but it's a summary of studies that have compared best supportive care, chemotherapy and targeted therapy in colorectal peritoneal metastases. But it's just an illustration of the fact that, in fact, systemic chemotherapy works in peritoneal metastases, although it's less efficient than in patients with liver or lung metastases. So intraperitoneal therapy, why would we give intraperitoneal chemotherapy? Well, because of the pharmacokinetic advantage in the first place. And it's not the only form of intracavitary chemotherapy. We are using it in the bladder, so intravesical mitomycin C for early stage breast cancer. We are using it in the brain, so in the ventricles. It has been used in the lung, so anti-cancer aerosols, etc., etc. So there's a pharmacokinetic advantage, and this pharmacokinetic advantage is resulting from the fact that if you give something in the peritoneal cavity, it will of course be resorbed systemically, but this is a slow process. So it will very slowly go from the peritoneal cavity to the systemic compartment, and so the blood and the extracellular fluid. And from the systemic compartment, it will be rapidly, very rapidly be cleared through renal excretion or to hepatic metabolization. So one process is very slow, the other is very quick. And this then results in the fact that the systemic drug levels always stay very, very low, even if you use a high dose intraperitoneally. And so this is the pharmacokinetic advantage. You can use a high dose intensity in the peritoneal cavity, and the systemic absorption and the systemic side effects, because the side effects are depending on the plasma concentrations, will be quite limited. Also, there is a direct contact of the drug with peritoneal metastases, which are often very poorly vascularized. And there are some clinical studies on that have looked with all kinds of fancy techniques at the density of blood vessels and microvessels in peritoneal metastases. And it's really very, very poor if you compare it to liver metastases or lung metastases, for instance. And of course, you can administer so-called multimodal therapy. You can combine anti-cancer therapy with an anti-adhesive product to prevent adhesions after cytoreductive surgery, with antibiotics, other antimicrobial therapies, etc. So there is absorption from the peritoneal cavity to the systemic compartment. And there is a kind of a barrier, so-called peritoneal plasma barrier. But this barrier does not consist of the mesothelial cell layer. This is only one layer of cells. And if it's present or not, this will not affect the kinetics of the drug transport. And this has been proven in animal models, but also in a clinical study, that if you remove the peritoneum, it will not influence the absorption of the chemotherapy from the peritoneal cavity to the systemic compartment. And this is due to the fact that this barrier function is in fact consisting of the submesothelial stroma, which has all these capillaries and which has this interstitial matrix consisting of collagen, hyaluronic acid, other proteoglycans, fibroblasts, immune cells, etc., etc. So the barrier is here indicated in red, and the mesothelial lining itself does not really play a role in this barrier function. And so what are the mechanisms of drug transport if you give a drug in the peritoneal cavity? Well, there are two main mechanisms, diffusion and convection. So diffusion is driven by a difference in concentration. So it's a concentration gradient that drives diffusion according to the law of Fick. And there's a proportionality constant, which is called the tissue permeability factor. And then the second mechanism is convection. Convection is in fact driven by a difference in pressure, hydrostatic pressure. And here the proportionality constant is the hydraulic conductivity, and it's also called Darcy's law, which states that the mass transport of a drug due to convection is proportional or equals the pressure gradient times the hydraulic conductivity. So those are the two physical mechanisms. And of course, in reality or in practice, it's always a mixture of both diffusion and convection. It's never diffusion alone or convection alone. But the higher the hydrostatic pressure in HIPEC, for instance, and you fill the abdomen with liquid, and it's a water column of let's say 15 centimeters on average. And so there, convection will play a more important role compared to an aerosol therapy, for instance. So the extent of transport due to diffusion or convection is depending, of course, on a large array of variables that is related to the perfusate, and so the hydrostatic pressure, the temperature, the viscosity, the osmolarity, the charge of the electrolytes, etc., and the perfusate. It depends on a large series of properties of the drug, so its concentration, its molecular weight, fat solubility, water solubility, etc., etc. Also the charge again of the drug, because the peritoneal cavity, the lining of the peritoneal cavity has a negative charge, so it will be easier for positively charged molecules or nanoparticles to get transported into the peritoneal tissue. And then, of course, the properties, mechanical properties of the tissue are very important. The interstitial fluid pressure, I already explained to you the importance of that parameter. The hydraulic conductivity, the stiffness, the electrostatic properties, etc., etc. But that being said, we only have used a very limited amount of drugs for intraperitoneal drug delivery for colon cancer. It's mainly mitomycin C and oxaliplatin. For gastric cancer and ovarian cancer, cisplatin and carboplatin have been used, and in the Far East, like in Japan, Korea, China, there is some experience with the taxane, so paclitaxel and docetaxel, not as a high-pack therapy, but as a therapy with a implanted peritoneal catheter, like Portacat, which has then a Tenkhoff catheter attached to it, which is located in the pelvis, and then intraperitoneal chemotherapy is given every 6 weeks as a treatment cycle. So the taxanes are not really good candidates for HIPEC because, first of all, they are cell cycle specific, and so they only work in a fraction of the cancer cells that are in the S phase. That's one, whereas oxaliplatin and cisplatin are not cell cycle specific, so they always work irrespective of the phase and cell cycle of the cancer cell. And also the taxanes do not show any thermal enhancement. We know that cisplatin is well known to be thermally enhanced. And this is here in the last column on the right, and this plus sign. We know that cisplatin works much better with hyperthermia. There's a synergism, whereas with the taxanes, there is no effect at all. Its effect is not enhanced by hyperthermia. So the taxanes are probably a poor choice for HIPEC. But it can be used for catheter-based long-term intraperitoneal delivery, as it is done in the Far East for gastric cancer. They do it often in the neoadjuvant setting in patients with gastric cancer. So you may know that there has been a high-profile study of HIPEC with oxaliplatin in colorectal cancer, which was negative. It didn't work, although overall, the study showed a very promising survival in these patients, in the whole group. I think it was about 4 years, if I remember correctly. And this is really much, much better than what we have observed years ago. Like 20 years ago, the median survival of patients with colorectal peritoneal metastasis was a few months. And so now it's 4 years. But the HIPEC did not show an effect in this prodigious 7th study. So why didn't it work? Well, there are a number of explanations. It's possible that it was too short. The treatment duration was 30 minutes. It also was given in a high dose of glucose, so in glucose 5%. And again, this is probably not the ideal solution. I have personally abandoned using glucose 5% years ago. We now use peritoneal dialysis solution, so Physioneal, which has a much more balanced composition and is much less aggressive for the peritoneum. Also, the endpoint is maybe not very relevant. It's a local treatment, HIPEC, so maybe you should choose an endpoint that reflects local activity. For instance, survival free of bowel obstruction or peritoneal recurrence-free survival. That's probably the better endpoint for this local regional treatment. So the treatment time is uncertain, and of course with hyperthermia there remain some questions about its effectiveness in cancer patients and its safety. There are some studies that suggest that hyperthermia is eliciting an immune reaction, but on the other hand, we know that it elicits the production of so-called heat shock proteins, these HSPs. And we know that, for instance, heat shock protein 72 has definite tumor promoting properties. And so it's really a knife that is cutting in both edges, and we really need to understand better in animal models, but also in translational studies, the effect of hyperthermia in cancer patients. The morbidity of HIPEC is acceptable. In fact, there are now a number of reports that have shown that the mortality and also the risk of major morbidity after HIPEC is in fact comparable to any major surgery in general. And in my experience, the complication rate and the mortality rate is lower than that after esophageal cancer surgery or pancreas cancer surgery. But it's quite demanding procedure, both for the surgeon and for the patient. It often takes 10 hours, 12 hours, 15 hours. And you see this here reflected in the median length of stay. And so these patients are in the hospital for a median of 3 weeks. And so half of them stay longer than 3 weeks. And so it's quite heavy for the patients, but the risk of mortality is low. So this is the Kaplan-Meier estimates of the survival, the overall survival in these patients, and you see that there's absolutely no effect of adding HIPEC to cytoreductive surgery alone. But again, as you can observe, the median survival here, and it's it's between 42 and 48 months. And so all in all, the results are supporting cytoreductive surgery for colorectal peritoneal metastases, but not the HIPEC as it was used here. And so not the high dose HIPEC with high dose oxaliplatin and a short treatment time of 30 minutes. That's probably something we should abandon. In addition, there were 2 other disappointing studies with HIPEC using oxaliplatin. You see them here. So it's the ProFellowship study from France and the ColoPEC trial from the Netherlands. Both of these were multi-center trials, and this was the prophylactic setting. So this means that HIPEC was used in patients at risk for peritoneal metastases, but who did not yet have peritoneal metastases. And the inclusion criteria were a little bit different. In the Dutch study, the high-risk patients were defined as patients where minimal peritoneal metastases were resected, or patients had ovarian metastases, and so-called Krukenberg metastases, or had a perforated tumor. Whereas in the Dutch study, sorry, that was the French study, and in the Dutch study, it was either a T4 tumor or a perforated tumor. So not patients with minimal already resected peritoneal metastases, and so resected during the primary operation, and also ovarian metastases were excluded in this Dutch study. But you can see that for the endpoints that were chosen, so in the French study, it was 3-year disease-free survival, and in the ColoPEC trial, they did use a local endpoint. So it was the peritoneal metastasis-free survival after 18 months, but no significant differences in both of these studies. So hyperthermia, is it useful? Well, we don't know yet. And what you have to realize when using hyperthermia or HIPEC is that, of course, you never can heat the tissue at the same temperature as the liquid that you give inside the peritoneal cavity. It's due to the heat sink effect. If you give a heated solution of 43 degrees inside the peritoneal cavity, the tissue will only reach like 41 degrees. This is because of the cooling effect of the blood vessels that are inside the tissue. It's similar to a cooling circuit of a car, of the engine of a car. It keeps it cooled, and this explains why you can never heat the tissue to a temperature of the same temperature of that of the liquid. And in fact, this is also observed when using radiofrequency ablation or microwave ablation of a liver metastasis. If the liver metastasis is very close to a large blood vessel, then it's impossible to effectively use either microwave ablation or radiofrequency ablation, because the heat will be carried away by the convective blood flow, and this is called the heat sink effect. So again, heat shock proteins, it's a concern. We don't really know what it means in clinical practice. We are now doing a study in patients with ovarian cancer where we leave cancer nodules in the abdomen behind, and we see what happens in terms of transcription of genes if the tissue, the cancer tissue, is exposed to hyperthermia. But what is certain is that, for instance, heat shock protein 90 here, the cartoon on the right side, really has some pro-tumor activities. It induces evasion of apoptosis, it sustains angiogenesis, etc., etc. So we really need to look into the details of the role of hyperthermia to make sure that we are not putting the patient at risk, because it has never been tested in a clinical trial. There are no randomized trials that have compared hyperthermic chemoperfusion, HIPEC, versus normal temperature perfusion. This has never been done. And so thermal enhancement of chemotherapy, it exists with cisplatin, but it's not that outspoken with oxaliplatin and mitomycin C. This is a study from the Netherlands. Here on the left side, this is an in vitro study where several cell lines were, or it's, I think, organoids. Yes, they created organoids. So the CMS1 type is more common in the primary colon cancer, and the CMS4 consensus molecular subtype is more prevalent in peritoneal metastases. And what you could see or observe is that, in fact, the thermal enhancement of oxaliplatin, but also of mitomycin C, is not very impressive, and it's less impressive in the CMS4, so the peritoneal metastasis organoids, compared to the primary tumor organoids. This is, I think, an interesting observation, but again, it's in vitro work. It's not a clinical observation. So what are the limitations of the current drug regimens that we use for intraperitoneal drug delivery? Well, first of all, sometimes the wrong drug is chosen. I have recently reviewed a manuscript where it was stated that in some patients the authors have used cisplatin. So cisplatin for colorectal peritoneal metastases. I mean, that's nonsense. We know that cisplatin doesn't work in colorectal cancer, so you should not do a HIPEC in patients with colorectal cancer and then use cisplatin, because it will not work. Also, the taxanes will not work. Paclitaxel will not work. But so the problem is that all the drugs that we use now for intraperitoneal drug delivery are off-label. None of these drugs have been specifically developed or approved for intraperitoneal drug delivery. There are, of course, specific side effects. We know that oxaliplatin is really locally aggressive drug. It's a so-called vesicant agent, and it can cause, specifically if you repeat it, so-called encapsulating fibrosis or cocoon formation. It's not that common. It's quite unusual, but I have seen it in a few patients, and it's really a problem. The whole bowel gets encapsulated with a very thick layer. It can be like 2 or 3 millimeters thick layer of fibrosis, and in order to remove that, it's very, very difficult, very risky, and it takes you hours and hours. So it can be a real clinical problem for the patients. What we also have observed with oxaliplatin is autoimmune thrombopenia. This is quite rare. I've seen it once or twice, and we've done hundreds of patients with HIPEC with oxaliplatin. But it's also something that has been described with systemic treatment using oxaliplatin. And so the oncologists all know that this can occur. And so it's an autoimmune mediated thrombopenia, which can be quite severe. I've known one patient who had no thrombocytes at all, 0 thrombocytes. So she, because it was a female patient, was on the intensive care for observation for a few days until the thrombocytes then recovered. But it's a temporary phenomenon. Usually after a few days, it recovers. Cisplatin, of course, which is used for HIPEC in ovarian cancer and in gastric cancer, is known to be toxic for the kidneys, and we always use systemic sodium thiosulfate as an antidote. And so systemic intravenous sodium thiosulfate, which will then capture the platinum that is systemically absorbed. The tissue penetration of intraperitoneal chemotherapy is quite limited. It's a few cell layers. I have written here 1 millimeter, but in fact, it's less than 1 millimeter. It's a few cell layers. And this is explained by the fact that the hydraulic conductivity of tumor tissue is very, very low. And so tumor tissue is not permeable for water and for liquid transport. And then also the residence time of HIPEC is very short. As I explained you, the Prodesia trial, which was negative, and also the other prophylactic trials used 30 minutes of treatment, and this is just not enough. We now use, since years and years, we have done the HIPEC for 90 minutes, and I know there are centers in the US who do it for 2 hours. And I think this is better. We have good arguments from in vitro studies where we look at the correlation between exposure time and cancer cell kill, and this is just clear that it's time dependent, and so you need to give it long enough, or ideally you should repeat it, because not all cells will be killed after a single treatment. That's why we give systemic chemotherapy in cycles, and we give 6 cycles or 12 cycles of chemotherapy and not one-time chemotherapy, and this is because, again, not all cells will be sensitive at the same time to the effect of the chemotherapy, and you need to repeat it. And so that's a major limitation of HIPEC, of course, which is done only once. So how can we improve that? The answer is twofold. We can use or develop the so-called prolonged delivery platforms, or we can use nanoparticles. We are working on both. And so prolonged delivery platforms are typically gels. And so they can be thermosensitive or they can be pH sensitive. And so it's a product that is liquid at room temperature. And once you give it inside the abdomen, it forms a gel. And this gel will then cover the intestine and the abdominal wall and the liver surface. And it will very slowly release the drug into the peritoneal cavity. And this can then ideally be combined with nanoparticles, nanoparticles which again will be slowly released into the peritoneal cavity and will be less quickly absorbed to the systemic compartment compared to small drugs such as doxorubicin or oxaliplatin or cisplatin. All of them are very small. And when choosing a nanoparticle, which is typically around 200 nanometers, you have to make a good choice, because if they are too small, like 10 nanometers, they will be very rapidly cleared, so just as a small molecule. And if they are too big, like in the range of more than 1 micrometer, and so 1000 nanometers, they will cause foreign body reactions, and they will cause fibrosis and toxicity. And there is at least one clinical trial of an intraperitoneal microparticle, so size of more than 1 micrometer, which was stopped due to toxicity. And the toxicity was due to foreign body reactions and fibrosis, excessive fibrosis. So this is, for those of you who are interested, I don't know if the citation is present here, but this is just an overview of prolonged release platforms that have been developed. And so gels, implants, textiles, etc., etc. All of this has been tested in preclinical models and animal models, and we're now developing a pH-sensitive gel together with the University of Utrecht in the Netherlands, where we hope that it will be available for phase 1 clinical studies very, very soon, probably next year. This is an example of a study that we did in our lab. It's a rat model of ovarian cancer, and we have used a prolonged delivery platform consisting of gelatin loaded with microspheres. And so these microspheres contained paclitaxel, so a Taxol. And what you could see here on the left side is, in the y-axis, the peritoneal cancer index in these rats. You see that when we used the Sorry, I have to answer my phone. Yeah. 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 Ah ja, maar daar moet ik niet meer komen, veronderstel ik. Wat is het? Ja. Okay.
This meeting is being recorded.
Sorry about that. I'm on call
It's okay.
unexpectedly, and I had to answer my phone. So what you see here is that the microspheres loaded with paclitaxel in the gelatin are really very, very effective compared to the control animals treated with saline or to the animals treated with the normal Taxol formulation. And this translates into a better survival in these animals, as you can see here in the Kaplan-Meier plots on the right side. And this is an example of these gels. This is again an animal model. This is not our work, it's from the literature. But I think it's a very interesting concept to inject a gel system which is loaded with nanoparticles and which then slowly releases the chemotherapy or the immune therapy or whatever product that you want to give inside the peritoneal cavity over the course of a few days or weeks. And so this is the new kid on the block. It's called PIPEC, or pressurized intraperitoneal aerosol chemotherapy. It's not an alternative for HIPEC, not at all. It's a palliative treatment. It's in fact indicated in patients who have unresectable disease. And typically it's a patient with gastric cancer or cancer of the pancreas, where you have very, very numerous but very small peritoneal metastases. In those patients, it really is a treatment that can be beneficial. Of course, we don't have any large randomized trials yet. We do have a number of retrospective trials of phase 1 trials, and we have now just finished a phase 1 trial using Abraxane, so the nanoparticle of paclitaxel in patients with unresectable peritoneal metastases. And we have now animal models. This is a rat model of PIPEC, so of aerosol chemotherapy, but we now also have a mouse model. And we have done several experiments. This is one of these experiments where we could show that you could nebulize messenger RNA and that this really is possible without breaking down the RNA. So the structural integrity of the RNA is preserved after nebulizing. And so one of the future treatments that I think will maybe be a better alternative than oxaliplatin and all these cytotoxic drugs, which also are very aggressive for the peritoneum itself, for the mesothelial lining, is immune modulating therapy, which can, for instance, after surgery, be sprayed on the peritoneal surface using a gel. And there is a proof of principle. This is, for instance, a often cited paper where an immune modulating gel was sprayed on the wound bed. And it's not a peritoneal metastasis model. It's an animal model where a subcutaneous tumor, I think it was colorectal, but I don't remember the tumor type. It was created in the animal on the back, and then it was surgically removed. It was excised, but a very small amount of cancer was left behind, like a small rim was left behind. And then they sprayed the wound bed with this kind of immune modulating gel. It's an anti-CD47 gel, which then stimulates the macrophages and the dendritic cells. And this then prevented the recurrence of the tumor and also created sensitivity to immune checkpoint inhibitors. And I think this is really a very interesting option, or a very interesting way to use immune modulating therapy in patients with peritoneal metastases from colorectal cancer. So to conclude, treatment of colorectal peritoneal metastases remains a challenge. We have now some novel insights into the pathophysiology of peritoneal metastases, but in fact, a lot remains to be demonstrated, and a lot is unclear, like the tumor microenvironment, the immune composition of the peritoneal cavity and of peritoneal metastases is really unknown, and we're now looking into that with single cell sequencing, with flow cytometry, etc., etc. There have been 3 large randomized trials that did not show a benefit of HIPEC with oxaliplatin, at least not with a high dose, short duration HIPEC, which was then dissolved in dextrose 5%. So we really need better treatments, longer duration, and some areas of potential progress are the use of prolonged delivery systems like gels, depots, biomaterials, and this then allows a prolonged low dose exposure of the cancer to the therapeutic substance. This is sometimes called metronomic delivery. And so metronomic delivery or metronomic chemotherapy means that you give a prolonged, so a very prolonged, but low dose chemotherapy, which is not toxic and which is known to prevent resistance of the cancer cells to the drug. And then also engineering of the tumor microenvironment using immune modulators is, I think, an exciting possibility. And what we are doing right now in the lab is to test toll-like receptor agonists like imiquimod, resiquimod. There are a number of products available already. Also experimental TLR agonists to give them intraperitoneally and to see if we can then make the tumor sensitive to immune checkpoint inhibition, and so immune therapy. And then personalized therapy, I did not discuss that in detail, but a number of centers worldwide have now developed organoid platforms, which are of course very expensive and not always easy to establish. But once you have organoids up and running, it's really ideal as a platform to for drug sensitivity testing, and specifically in patients who have failed like 1, 2, 3 lines of chemotherapy. Then the question is, yeah, what can we give next and what will work? Because we know that 4th line therapy, for instance, will work in only about 10% of patients. So if you can then use or make organoids from the tumor tissue of the patient to test which drugs or targeted agents will work, that would be, of course, a major advantage or a major asset. So that was my last slide. I would like to thank again the organizer for the kind invitation, and I apologize for the short interruption, which was due to the duty from the hospital calling for a short moment. So thank you for your attention.
Thank you, Dr. Wim. We can start by taking questions from the audience. Please, if you have a question, raise your hand. I personally have a question. Because I keep reading a lot about them, the heat shock proteins, but I don't understand their importance. So can you please elaborate, explain to me in a simple sentences, what is the importance of heat shock proteins?
Yeah. Well, heat shock proteins are expressed by healthy cells, but also by cancer cells when they sense a heat stress. So it's a specific mechanism that will then induce transcription of DNA and of genes that code for these heat shock proteins. And there are like 5 or 6 important ones. They are identified by numbers, like heat shock protein 70, heat shock protein 92. And we know that some of them have potentially a tumor promoting role. Not all of them, and some of them have anti-cancer roles or anti-tumor roles, but some of them have, in theory at least, they have been known to be pro-tumorigenic. So that is the how would I say, the caveat or the worry when you use hyperthermia. It's true that there are some studies that show that you can stimulate the immune system, but other studies show that these heat shock proteins have potentially a negative effect. And that may be, of course, it's just a theory, but that may be one of the explanations for the fact that the HIPEC trial did not work, because maybe the effect of the oxaliplatin was negated by adverse effects of the hyperthermia. But again, that's just a theory. We don't know that, and that's something we urgently need to test in translational studies. And we have to do measurements in patients to see which heat shock proteins are being produced and how they correlate with the survival of the patients.
Okay, thank you. Any other questions? Please, if you have a question, raise your hand. Any questions from the audience? Any questions to Dr. Wim Ceelen? Looks like your presentation was perfect. Everybody understood everything and they have no questions.
That's great. If you want, I can send the PDF to you and you can distribute it to those who have listened or those who could not attend. So
yes,
you're welcome
please.
to.
I will send you the recording on YouTube because I post the video later for people who couldn't attend.
Okay, that's great. So thank you again for the invitation, Hisham.
Thank you, Dr. Wim, and hope to see you in a conference soon.
Yeah. See you soon and have a nice evening.
Thank you.
Bye.
Thank you for joining us.
Bye.
باي باي. الخميس الجاي يا جماعه في ويبينار، في ميعاد خدناه زياده، بس يوم الخميس الجاي الساعه 9 هيبقى في ويبينار. شكرا.